Good morning, everyone, and very warm welcome to Surgical Grand Round. Today, I have the honor and pleasure to introduce Professor Paul Sugarbaker, who has kindly agreed to deliver our Surgical Grand Round. We all aspire to stand on the shoulders of giants, but when it comes to Professor Paul Sugarbaker, there is no doubt that we are all truly standing on the shoulders of a giant. Professor Paul Hendrik Sugarbaker has been at the Washington Cancer Institute since 1989 as a director for the program in peritoneal surface malignancy. His interests are in gastrointestinal cancer, gynecological malignancies, and mesothelioma. Dr. Sugarbaker is a strong critic of surgical tradition. He believes that major changes in the technology of cancer resection are necessary. His theme is "What the surgeon doesn't see that kills the patient" summarizes the concepts behind many of his publications in the peer-reviewed medical literature. In the opinion of Dr. Sugarbaker, preoperative intravenous and intraperitoneal chemotherapy are an essential planned part of many cancer interventions. And today, he will kindly take us through the prevention of tumor cell entrapment in local and regional control of gynecological cancer. Paul, the floor is yours.
Okay, Hooman, thank you so very much for the invitation to speak at this prestigious Grand Rounds. I don't often get this privilege, and I'm going to focus on a disease that is, I think, very timely, not only for the gynecologic surgeon, but also for colorectal surgeons, hepatobiliary surgeons, thoracic oncologists, and you'll see that many members of the surgical team are now getting involved with the resection of ovarian malignancy. Thanks to the audiovisual team, Louise King and her group, we hope that this all moves smoothly. If I could have the next slide, please. And then the next. So this is the thesis from which I'm working here this morning. Improved local control of gynecologic cancer is the most likely strategy to improve disease-free survival. When the surgeon operates on ovarian cancer, he or she becomes a part of the natural history of that disease. And debulking surgery, which I think is still the standard of care for ovarian malignancy. And we should contrast it with complete cytoreduction, which is the removal of the disease down to no visible disease left behind. I'm going to go so far as to say that this debulking surgery usually does more harm than good regarding local regional control. Next slide. So in order for us to get started, I think we need to throw out some old concepts for the management of ovarian malignancy and replace them with a new concept. And these manuscripts from a long time ago, Griffiths, Hoskins, and then Bristow, they basically told us that resection of as much cancer as possible is what's good, and that one should do as much as you can, and perhaps the tools that the GYN oncologist was working with back there a decade or so ago were not the tools that we have now. But this concept that incomplete debulking improves survival is one we need to throw out. Next slide. I'm also going to make the point that hysterectomy and salpingo oophorectomy is not necessarily the standard of care for the first surgery for ovarian cancer, and that unfortunately hysterectomy is an innocent bystander very often in the management of this disease, and we're focusing way down in the pelvis, whereas the disease process is actually all over the abdomen. So I'm going to make a few comments about the friendly fire that hysterectomy often receives in the initial treatments of ovarian malignancy. And next slide. Unfortunately, and I've operated with a lot of surgeons performing cytoreductive surgery, oftentimes in a difficult part of the dissection, I hear it's that, oh, this is tough. This is a dangerous part of the cytoreduction. Let's leave this for the HIPEC. That's not the concept that I would like to present here. We can't rely on a complete and durable response to systemic chemotherapy to complete the cytoreduction. HIPEC or HIPEC plus EPIC is not an excuse for suboptimal surgery for primary or for recurrent ovarian malignancy. Next slide. So you're going to hear a lot this morning from me about tumor cell entrapment. You know, I could give this talk for gastric cancer, certainly for pancreatic malignancy, and for colon cancer. Not so much, of course, for rectal malignancy, because we're quite good with our preoperative chemoradiation in gaining control of tumor cell entrapment within the pelvis. Wasn't always true. When I was training for surgery at the Peter Bent Brigham, we had a 40% incidence of disease recurrence in the pelvis with rectal cancer, and it's amazing how that has changed over the course of years. So, what is tumor cell entrapment? Well, it says that when surgery disrupts the peritoneum as the first line of defense against peritoneal metastases, there's enhanced cancer progression that occurs at this resection site. And for ovarian malignancy, the most problematic sticky surface after the peritoneum has been removed is the pelvis and the hysterectomy site. Next slide. And next. So this is a little schema of what, go back one, please. Back one slide. Yeah, here we go. This is perfect. So this is a schema of what, next slide. This is a schema of what tumor cell entrapment is, and there's a number of ways in which tumor cells gain their access to the peritoneal space and result in peritoneal metastases. Serosal invasion and surgical trauma can free up cancer cells. Lymphatic invasion. When we transect lymphatics, we release tumor cells at the resection site, and the same goes for venous invasion. Bleeding from the cancer specimen, I think is a huge problem, and something that should be prevented as much as possible. We then have free intraperitoneal tumor emboli in stage 3 ovarian cancer. They're there even as we start the procedure, but these tumor cells become entrapped within fibrin. They adhere to sites where the peritoneum has been removed, and then there's inflammatory cell infiltrate growth factors, and the tumor, the cancer cell becomes vascularized, and we have an implant. Next slide. And I'd call your attention to the fact that there's really 2 different manifestations of this intraoperative dissemination of cancer cells. If we have single cells and a low density of peritoneal seeding, then we have peritoneal metastases. But if we have a high density of seeding at the resection site, then we're going to have a fusiform layering of tumor. And unfortunately, in ovarian cancer, very often we have this layering of cancer within the pelvis after hysterectomy. So two different manifestations are two different ways in which we're going to see peritoneal dissemination as a part of a cancer resection. Next slide. So in considering tumor cell entrapment, there are some diseases much more likely to be effectively treated by perioperative chemotherapy, and those are the ones with positive peritoneal cytology. And I think we've had remarkable success with pseudomyxoma peritonei and really all the appendiceal malignancies where there is a perforation of the appendix. A rare disease which has shown considerable improvement with our techniques of cytoreduction and perioperative chemotherapy is peritoneal mesothelioma. But now we're getting into success with some other much more common diseases that have a positive peritoneal cytology, and gastric cancer is one of those. And then this morning we're talking about ovarian cancer. I've made a number of tries with pancreas cancer, but that's a whole nother subject, but probably a very important one as that disease becomes more and more prevalent. The next slide. So I'm going to present a little bit of evidence from my own experience that this tumor cell entrapment is an important part of the natural history of ovarian malignancy when hysterectomy has been used in the treatment of primary ovarian malignancy. This is the diagram that we use for the prior surgical score. It's basically a tic-tac-toe of the abdomen, and all of the prior surgery that's been performed can be summated as a prior surgical score, and a PSS of 0 is that only a biopsy was performed or laparoscopy. Prior surgical score of 1 is a minimal exploration of one region. prior surgical score of 2, well, means, okay, we've performed the hysterectomy and perhaps a partial omentectomy, and then prior surgical score of 3 is extensive prior surgery. And by the way, I think that this particular concept of being aware of what went on prior to your entrance into the abdomen is very important in how that patient is managed. So next slide. So this is my own personal experience with ovarian malignancy and the assessment in these patients now who have had reoperative surgery for ovarian cancer. This is a slide of I think it's 52 patients who had reoperative surgery for ovarian malignancy. And we can see on the solid line, there's not so many people up, patients up there, but if there's not been much surgery, perhaps most of these patients just had an oophorectomy, and maybe the disease was so advanced that that's all that was done. But when I operated on them and did cytoreductive surgery in HIPEC, those patients who had a less extensive prior surgery did so much better than those patients who had had basically a prior attempt at cytoreductive surgery, and I'm blaming that poor result on tumor cell entrapment that occurred after the prior surgery for ovarian cancer. And then the next slide. And this is my own experience with patients who have had a hysterectomy, no HIPEC. So a hysterectomy and HIPEC for no HIPEC for primary disease, and I reoperated on these patients, and this is what I found. So up underneath the right hemidiaphragm, we had a very high incidence. That's the first line in the table here. Undersurface of the right hemidiaphragm, 70% of patients had disease there, and of course, that's really just persistent disease. These people did not have a stripping of the undersurface of the right hemidiaphragm or a cleaning of Glisson's capsule. And then the greater omentum was also a common site for recurrence. And for the most part, this was disease in the gastrosplenic ligament. I think the gastrosplenic ligament is for the most part kind of not resected as part of the omentectomy by a gynecologic oncologist. I think that's a mistake. The complete omentectomy should be performed, but we certainly had a lot of recurrences within the greater omentum. Now, we also had a lot of recurrences in areas that should be clean of ovarian cancer at the close of the hysterectomy. For example, the abdominal incision is not part of the original disease, but it is certainly a part of the disease when you are performing a reoperation, and laparoscopy port sites are also very often positive. And another area that's laid where the peritoneum is removed is that bladder flap, or the visceral surface of the bladder, and high incidence of disease at that site. And then the vagina, the poor vagina, 50% of the patients that we reoperated on had disease at the apex of the vagina. Now, that's not part of the original pattern of dissemination. That disease that I found at reoperative surgery, I think must be attributed to a tumor cell entrapment. And then there's some areas where there's a high incidence of tumor cell entrapment, which have a profound effect upon survival. And that's it comes from the fact that in order to perform a hysterectomy, you need to free up the tissues in and around the distal right and left ureter. And we had a high incidence of disease in and around the distal part of the right and the left ureter. And a number of these patients did require resection of the distal ureter and a reimplant into the bladder. And even a few of them had bilateral ureteral vesicle reimplants. So from my own personal experience, I'm convinced that the surgery for primary ovarian cancer has a profound effect on the natural history of this disease. So next slide. So why don't we just leave the uterus behind if it's possible? That's not always possible, but it is possible. And one of the reasons why people say, oh well, you should always perform a hysterectomy with primary ovarian cancer is that the lymphatic drainage of the ovary is through the myometrium, and that's not true. The lymphatic drainage is all superior and not inferior along the infundibulopelvic ligaments and the like, and is not into the uterus. And next slide. And a lot of people are saying, oh, well, you have to take out the uterus because a certain percentage of these patients will have an endometrioid type of ovarian malignancy, and it's going to be present in both the uterus and in the ovary. And that is true. But I think that we can detect those patients with a pelvic ultrasound, or I have to say, in my experience, we always did a curettage of the uterus if there was any suspicion that this was an endometrial type of ovarian malignancy. I have to say they really look different, and so in this particular manuscript, Dr. Bunting said that routine hysterectomy, because there was an endometrioid cancer, is really not an argument for always performing hysterectomy. Next slide. So take-home message for me for this first 20 minutes or so of the presentation is that hysterectomy in patients with primary ovarian cancer is indicated only when required to facilitate complete cytoreduction. And you know, it's the same in our work with pseudomyxoma peritoneal. We try hard not to expose the ureters and to strip the pelvis unless it's necessary. You know, the uterus is an innocent bystander, unfortunately, I think, in a lot of ovarian cancer surgery. And debulking surgery with hysterectomy, tumor cells left behind, hysterectomy performed, I think that jeopardizes a favorable outcome, primarily because of the disease that is recurrent in and along the ureters. Now, if you can remove all the disease, you're going to have a favorable outcome. And let's go to the next slide. So this is an old manuscript, but I think that, you know, where the Oxford group is perhaps at this point in time of thinking about now upper abdominal surgery as well as a lower abdominal surgery for ovarian malignancy, we need, as Dennis Chi did back here in 2009, we need to get the hepatobiliary surgeons involved in ovarian cancer and the colorectal surgeons involved if necessary, and sometimes even thoracic surgeons where we have disease up involving the right and left hemidiaphragm. So just quickly, in this really nice manuscript, I think it's really a classic manuscript by the Memorial Sloan Kettering group. In this group 1, they did a cytoreduction, you know, the way it's kind of classically performed by a GYN oncologist. And then in the second group, they really pulled out all the stops. And those patients had not only the disease in the pelvis removed, but the upper abdominal disease was also removed with the proper surgical expertise being brought into the operating room. And it made a difference in the progression-free survival, big difference in the progression-free survival, but also a real difference in overall survival. And next slide. And we can see here on the right lower Kaplan-Meier survival curve that the surgery itself and a more complete removal of the disease with ovarian cancer in and of itself. This is before the HIPEC era. In and of itself made a big difference. And the next slide. And I think it's important to see that there was a different kind of surgery. So early on in this group 1, very seldom was the rectal sigmoid colon resection performed, but in 35% after this effort to do a soul satisfying surgical complete cytoreduction. And there's a huge difference in the amount of disease that was removed in the upper abdomen. For example, stripping of the undersurface of the hemidiaphragms, 35% of patients as opposed to none in the past. And the spleen was removed as part of the greater omentectomy and in a fair number of patients. So anyway, there was a large change in both the pelvic surgery and the upper abdominal surgery. Next slide. So my take-home message from the discussion of cytoreduction is that cytoreduction, complete cytoreduction in and of itself can improve survival in ovarian cancer patients. But then I'd like to move now from really move from the first requirement for effective HIPEC, which is a complete cytoreduction. And I'm going to just quickly present some of the data that suggests that perioperative chemotherapy, and for the most part, that's HIPEC, although it's not just HIPEC for a number of groups, but perioperative chemotherapy is something that I think is very important and will become more important with the management of ovarian cancer. Next slide. So the preoperative chemotherapy or neoadjuvant chemotherapy can be of help. We see in colorectal, appendiceal, and gastric cancer that effective neoadjuvant chemotherapy is probably the most important aspect of a good result with complete cytoreduction. I don't know whether that's true for ovarian cancer or not, but I suspect that it is. And And certainly neoadjuvant chemotherapy is an important part of this story. Next slide. And I think that we need to be careful that we don't overextend ourselves with the cytoreductive surgery. I'm convinced that the women with less extensive metastatic disease will do better with primary surgery, and those with more advanced disease should have the neoadjuvant chemotherapy. So my talk here today is not to try and discontinue the neoadjuvant chemotherapy for ovarian cancer. So next slide. So there's a lot of single institution reports, many, dozens, that suggest that cytoreductive surgery with HIPEC is a superior way to manage ovarian malignancy. And this is a study from the French group, and they really, it's an old study from 2012, but I think that it gave us courage to move ahead with the randomized studies for HIPEC in ovarian malignancy. Next slide. And I'm showing this slide, which is really the first one. And John Spilotus is a good friend of mine, and so I'm showing his data, which I think is often neglected. This is the first trial that suggested that a randomized controlled study that suggested that HIPEC was of value in an RCT for ovarian cancer. And this is recurrent epithelial ovarian cancer. And I respect the data that John presented and had presented and had published in the Annals of Surgical Oncology. And next slide. And this, of course, is the most important study, which is HIPEC with interval cytoreduction of ovarian malignancy. And Wilhelmina Van Driel used a very conservative HIPEC here. She had 100 milligrams of cisplatin with thiosulfate. Didn't have an adverse effect on the morbidity or mortality in these patients, but really a remarkable, I think, improvement. You know, this is the first improvement in the management of ovarian cancer in about 20 years, but a remarkable improvement when complete or near complete cytoreduction and HIPEC were used for stage 3 ovarian cancer as compared to surgery alone. Next slide. So I have to just interject here a personal bias regarding the improvement in the margin of resection and a decrease in the dissemination of tumor as a result of the dissection itself. And Hooman's been at one of our video workshops for cytoreductive surgery. In these video workshops, we focus actually a full day on what happens in the operating room. And so as a little parenthesis here, I'm going to say that I think that the dissection tool that you use is important, and I'm going to put in a plug for a ball tip electrosurgical dissection at high voltage as a tool which minimizes the cancer dissemination as a result of the trauma from surgery. And next slide. So I would like to suggest that we're basically at the infancy of perioperative treatments for ovarian malignancy, for a perioperative treatment being added on to that optimal cytoreduction. So I'm showing you here the regimen that I've used for the last almost 20 years, which is a cisplatin-based regimen, but it's not a single agent. Now, Wilhelmina used 100 milligrams per meter squared of cisplatin with thiosulfate rescue, and she did something which I think is very important and we need to pay attention to. She had chemotherapy installations at 3 different times during that 90 minutes of HIPEC. And that's a kind of a Dutch, that was started by Franz Zultmulder with mitomycin C almost 30 years ago, and has been continued as part of the Dutch routine for administering chemotherapy over 90 minutes. You give half of it at the start, and then at a half an hour, a quarter, and then at another half hour, a quarter. So you have a little bit a more uniform chemotherapy administration. So I say that in applause to the Dutch regimen for cisplatin administration. This is the regimen that I have used, and it is a multi-drug regimen. It's cisplatin at 50 milligrams per meter squared, but without thiosulfate rescue. And then a very good drug for ovarian malignancy is doxorubicin. And that's the maximal amount of doxorubicin, 15 milligrams per meter squared, that you can use without getting a peritoneal sclerosis. Now, there's not just a peritoneal or an intra-abdominal or intrapelvic side to the peritoneal lining. There's also a body side, and so we use an intravenous agent as a continuous infusion for 90 minutes of the HIPEC, and it's this ifosfamide, very good drug for ovarian malignancy, and it's a heat sensitized drug, so that the ifosfamide has about 10 times its cytotoxicity at 41.5 degrees, which is the peritoneal surface, as it does in the body compartment. And of course, if you use ifosfamide, you have to use some agent to protect the uroepithelium, and we would use Mesna. So that's the Sugarbaker triple drug regimen for ovarian malignancy that's had a complete cytoreduction. And next slide. And I'm not content with a surgery in the operating room. We would use an installation of paclitaxel. And this would be for the first 5 days post-operatively. We would use 20 milligrams per meter squared, and that would bring us to 100 milligrams per meter squared of paclitaxel. And that's instilled into the peritoneal space in Hespan or a dextran solution. And the pharmacokinetics of paclitaxel in a starch solution is much better. The area under the curve is quite a bit higher, about 50% larger, because the paclitaxel stays around longer, because the fluid within the abdomen stays around longer. And I think it's a very good way of minimizing adhesions in these patients. And from a quality of life perspective, adhesions are a huge problem in patients who have cytoreductive surgery. And this paclitaxel installation in a dextran solution is not only good for the treatment of the peritoneal metastases, but is a real powerful tool for minimizing the adhesive process. Next slide. So this is my final slide. Only perform hysterectomy with primary ovarian cancer when it's necessary. Of course, if it's necessary to remove the uterus in order to have a complete cytoreduction, that is absolutely perfect reason to perform a hysterectomy. But just to have it as part of the a routine part of the primary treatment of ovarian cancer doesn't make any sense to me. In other words, if you're going to have disease left behind at the root of the mesentery with seeding and the like, and you leave and then you remove the uterus because it has one or two little nodules on its surface, which easily could be removed, you just don't understand. You just don't understand the natural history of peritoneal metastases. So the best way to avoid tumor cell entrapment is with a complete cytoreduction. And then I use perioperative bidirectional chemotherapy, both intravenous and both intraperitoneal and intravenous drugs. Of course, we need to use the neoadjuvant chemotherapy knowledgeably to reduce the PCI. And I'm going to suggest to you that the perioperative chemotherapy treatments for ovarian cancer, the Vandriel regimen, which has served us so well and is by consensus the standard of care at this point in time, is really kind of a first step in the effective treatment of tumor cell entrapment in ovarian cancer patients. And I think that's my final slide, so I'll stop there. And if we have some time for questions, I'd love it, because then I might be able to learn something here.